Welcome, everyone. Today, we're shedding light on a common yet often underestimated health issue: urinary tract infections, or UTIs. More than just a minor inconvenience, UTIs can disrupt daily life and lead to serious complications if left untreated. Think of your urinary tract as a well-orchestrated system. When harmful bacteria invade, the balance is thrown off, causing discomfort and potential health risks. Over the next few minutes, we'll explore how UTIs develop, how to spot the warning signs, and the best ways to treat and prevent them. Let's get started. Historical perspective on UTIs. UTIs have challenged humanity for millennia. Hippocrates documented symptoms resembling cystitis over 2,000 years ago, yet effective treatments remained elusive for centuries. The 1950s marked a turning point with the introduction of nitrofurantoin, a breakthrough that finally offered relief. Earlier therapies, like early 20th century chemotherapeutic agents, often failed, leaving patients to endure weeks of ineffective treatment. Today, we have advanced antibiotics and diagnostic tools, but the rise of antimicrobial resistance reminds us that progress must never stagnate. By learning from the past, we can forge a safer future. Defining urinary tract infections. UTIs aren't a one-size-fits-all diagnosis. An uncomplicated UTI is like a contained spark, a bladder infection in a healthy individual, easily managed with short-course antibiotics. Complicated UTIs, however, are wildfires. They occur in patients with underlying conditions like diabetes, kidney stones, or weakened immune systems, requiring prolonged and tailored treatment. Then there's asymptomatic bacteriuria, bacteria silently colonizing the urinary tract without causing symptoms. Recognizing these categories ensures we treat wisely, avoiding unnecessary interventions while addressing true threats. Epidemiology of UTIs. UTIs disproportionately affect women. Up to 80% will experience one in their lifetime. Hormonal changes, anatomy, and lifestyle factors contribute to this disparity. After age 50, men's risk rises due to prostate issues. Pregnant women face heightened vulnerability, as untreated infections can harm both mother and child. Diabetics, too, are at greater risk. These statistics remind us that UTIs touch nearly every demographic, but awareness and proactive care can mitigate their impact. Risk factors for UTIs. Why do some individuals face recurrent UTIs while others never experience one? For women, factors like sexual activity, contraceptive use, or a family history of UTIs play a role. Men often grapple with prostate enlargement or anatomical abnormalities. Across genders, conditions like diabetes, urinary retention, or catheter use increase susceptibility. Recognizing these risk factors isn't just about diagnosis. It's about empowering patients to take control of their health. Etiology of UTIs. The majority of UTIs stem from familiar culprits. Escherichia coli causes up to 90% of uncomplicated cases, while Staphylococcus saprophyticus often targets young women. In complicated infections, pathogens like Klebsiella and Pseudomonas join the fray, showcasing remarkable adaptability. Alarmingly, antibiotic resistance is rising globally, particularly among E. coli strains. This underscores the importance of tailoring treatments to local resistance patterns and preserving our antimicrobial arsenal. Pathogenesis of UTIs. Imagine bacteria as stealthy invaders. They ascend the urethra, evade the body's defenses, and latch onto bladder cells using hair-like structures called pili. E. coli, for instance, employs virulence factors like toxins and biofilms to thrive. The outcome of this microscopic battle hinges on the interplay between bacterial aggression and the host's immune response. By unraveling these mechanisms, we develop therapies that disrupt the invader's strategies. Upper and lower urinary tract. Infections. A lower UTI, cystitis, manifests as burning urination and relentless urgency. But when bacteria breach the kidneys, pyelonephritis sets in. High fever, flank pain, and systemic illness. Distinguishing between these isn't academic, it's critical. A bladder infection demands prompt care, But a kidney infection requires urgent intervention to prevent sepsis or permanent damage. Environmental factors in UTI pathogenesis. The vaginal microbiome acts as a natural shield against UTIs. Disruptions from spermicides, hormonal shifts, or sexual activity can tip the balance, allowing harmful bacteria to flourish. Anatomic factors like the shorter female urethra further facilitate bacterial ascent. Add urinary stasis from conditions like kidney stones, and the stage is set for infection. Protecting these natural defenses is key to prevention. Host factors in UTI. Pathogenesis. Why do some individuals suffer recurrent UTIs? Genetics may hold the answer. Certain blood types or cellular receptors make it easier for bacteria to adhere. Mutations in immune-related genes, like those encoding toll-like receptors, can weaken defenses. These insights remind us that UTI susceptibility is written in part by our DNA, but knowledge empowers us to rewrite the script. Microbial virulence factors. Bacteria are master strategists. E. coli's P. fimbria act like grappling hooks, anchoring to kidney cells to cause pyelonephritis. Type 1 pili allow bladder colonization, while toxins and metal scavenging systems ensure survival. Biofilms shield bacteria from antibiotics, turning infections into chronic battles. Understanding these tactics is the first step in outsmarting them. Clinical syndromes. Asymptomatic bacteriuria. Bacteria in the urine without symptoms. This is asymptomatic bacteriuria. For most, it's harmless and requires no treatment. Yet in pregnancy, it's a silent threat. Left unchecked, it can escalate to pyelonephritis, risking preterm labor. Here, treatment isn't optional. It's a safeguard for both mother and child. Clinical syndromes. Cystitis. Cystitis transforms routine urination into a painful ordeal. Patients describe it as passing razor blades, burning, urgency, and relentless frequency. While rarely life-threatening, it disrupts daily life and demands timely care. Prompt treatment not only relieves suffering but also prevents upward spread to the kidneys. Clinical syndromes. Pyelonephritis. Pyelonephritis is a systemic crisis. High fever, shaking chills, and agonizing flank pain signal that bacteria have invaded the kidneys. Without swift intervention, complications like abscesses or sepsis may follow. This isn't just a UTI, it's a race against time to protect renal function and save lives. Emphysematous pyelonephritis. In diabetics, a UTI can take a deadly turn. Emphysematous pyelonephritis, a gas-forming kidney infection, is a surgical emergency. Mortality rates soar without rapid drainage, antibiotics, and sometimes nephrectomy. Vigilance in high-risk patients is non-negotiable. Xanthogranulomatous. Pyelonephritis. Chronic obstruction and infection can transform kidney tissue into a yellowish, tumor-like mass. Xanthogranulomatous pyelonephritis mimics cancer, often requiring nephrectomy for cure. It's a rare but stark reminder of how neglect or delayed care can lead to irreversible damage. Clinical syndromes. Prostatitis. Men aren't spared from UTIs. Acute bacterial prostatitis strikes suddenly. Fever, pelvic pain, and urinary retention. Chronic cases linger, eroding quality of life. Treatment demands prolonged antibiotics and addressing prostate involvement, highlighting the need for patience and precision. Clinical syndromes. Complicated UTI. Complicated UTIs defy simplicity. Underlying conditions, catheters, stones, or diabetes fuel these infections, often involving resistant pathogens. Success hinges on two pillars: targeted antibiotics and addressing the root cause. Each case is a puzzle, demanding both clinical acumen and collaboration. Diagnostic approach to UTIs. A patient's story is the first clue. Symptoms like dysuria and urgency point to cystitis, while fever and flank pain signal pyelonephritis. Urine dipsticks offer rapid answers, but cultures remain the gold standard for complicated cases. Balancing speed with accuracy ensures no time is wasted and no treatment is misplaced. Diagnostic algorithm for UTIs. For uncomplicated cystitis, symptoms alone may suffice for diagnosis. Uncertainty? A dipstick test can confirm. High-risk patients, pregnant women, men, or those with comorbidities, require cultures to guide therapy. This structured approach minimizes guesswork and maximizes outcomes. Differential diagnosis of dysuria. Burning urination doesn't always mean a UTI. Sexually transmitted infections, vaginitis, or even bladder cancer can mimic symptoms. In young women, chlamydia is a common confounder. A broad differential ensures we treat the right condition, not just the obvious one. Diagnostic approach to UTI. Visualizing the diagnostic pathway clarifies decision-making. Algorithms provide structure, but clinical judgment, rooted in patient history and exam, remains irreplaceable. Together, they light the path to accurate diagnosis. Treatment principles for UTIs. Effective UTI management rests on three pillars: the right antibiotic, the right duration, and stewardship. Overprescribing fuels resistance. Underprescribing risks complications. Every prescription must weigh immediate relief against long-term consequences. Collateral damage in UTI treatment. Antibiotics save lives but disrupt ecosystems. Nitrofurantoin and phosphomycins spare gut flora, while quinolones and broad-spectrum agents wreak havoc. Choosing agents with minimal collateral damage isn't just wise, it's an ethical imperative in the face of rising resistance. Treatment of uncomplicated cystitis. In women, nitrofurantoin for 5 days or trimethoprim sulfamethoxazole for 3. These remain frontline options. Phosphomycin's single-dose convenience is ideal for adherence. Tailoring choices to local resistance patterns ensures efficacy while safeguarding future options. First-line agents for uncomplicated cystitis. Nitrofurantoin's enduring efficacy, even after 6 decades, speaks to its value. Trimethoprim sulfamethoxazole remains viable where resistance is low. Phosphomycin's unique mechanism and single-dose regimen make it a versatile tool. Trust these agents, but never complacently. Resistance is always evolving. Second-line agents for uncomplicated cystitis. Quinolones are potent but come with risks: tendon injuries, nerve damage, and resistance. Reserve them for cases where first-line options fail. Beta-lactams, while safer, often lag in efficacy. Prudent use today preserves options for tomorrow. Antibiotic sparing. Approaches. Mild symptoms? Consider delayed prescribing. Patients start antibiotics only if symptoms persist. Phenazopyridine alleviates pain but doesn't cure. These strategies reduce unnecessary antibiotic use, a small but vital step in combating resistance. Treatment of pyelonephritis. Pyelonephritis demands swift action. Outpatient management suits stable patients, with fluoroquinolones as first-line therapy. For the critically ill, hospitalization, IV antibiotics, and close monitoring are life-saving. Duration, 7 to 14 days, hinges on clinical response. Outpatient management of pyelonephritis. Stable patients can recover at home with oral fluoroquinolones. A single IV ceftriaxone dose bridges the gap if resistance is suspected. Follow-up within 48 hours ensures improvement and prevents relapse. Inpatient management of pyelonephritis. Severe pyelonephritis, marked by sepsis, vomiting, or dehydration, requires hospitalization. IV antibiotics like ceftriaxone or piperacillin tazobactam start the fight. Transition to oral therapy once the patient stabilizes, ensuring continuity of care. Treatment of UTI in pregnant women. Pregnancy transforms UTI management. Asymptomatic bacteriuria must be treated to prevent pyelonephritis and preterm labor. Nitrofurantoin and cephalosporins are safe choices, while sulfonamides and fluoroquinolones are avoided. Vigilance here protects two lives at once. Treatment of UTI in men. UTIs in men often involve the prostate. A 7-day course of fluoroquinolones or trimethoprim sulfamethoxazole targets both bladder and prostate infections. Chronic cases demand extended therapy up to 12 weeks to eradicate persistent pathogens. Treatment of complicated UTI. Complicated UTIs require a dual approach. Broad-spectrum antibiotics initially, then narrowing based on culture results. Addressing underlying issues, stones, catheters, or strictures, is equally critical. Persistence and adaptability turn the tide in these challenging cases. Special considerations. Xanthogranulomatous, pyelonephritis. Chronic obstruction and infection can morph kidney tissue into a destructive, tumor-like mass. Diagnosis hinges on imaging and histopathology. Surgery is definitive, but antibiotics play a supporting role. A rare yet instructive example of infection's destructive potential. Special considerations. Emphysematous pyelonephritis. Diabetic patients with gas-filled kidneys face a dire emergency. Emphysematous pyelonephritis demands immediate drainage, IV antibiotics, and often nephrectomy. Delayed intervention risks mortality, a stark reminder of diabetes' systemic impact. Special considerations. Papillary necrosis. Necrotic renal papillae. A complication of diabetes, sickle cell disease, or chronic NSAID use, can obstruct urine flow. CT imaging reveals sloughed tissue, while management focuses on relieving obstruction and treating infection. A race to preserve renal function. Treatment of asymptomatic bacteriuria. Treating asymptomatic bacteriuria is rarely justified, except in pregnancy or before urologic procedures. In the elderly, overtreatment fuels resistance without benefit. Let evidence, not habit, guide decisions. Catheter-associated UTI or CAUTI. Catheters, while sometimes necessary, are a leading cause of hospital-acquired UTIs. Diagnosing CAUTI is fraught. Symptoms are nonspecific, and thresholds differ. Prevention is paramount. Remove catheters promptly and use them only when essential. Changing the catheter disrupts biofilms where bacteria hide. Cultures guide targeted therapy, typically spanning 7-14 days. Prevention strategies, sterile insertion, timely removal, reduce CAUTI rates more effectively than any antibiotic. Management of candiduria. Fungal UTIs, often linked to catheters or broad-spectrum antibiotics, require a nuanced approach. Asymptomatic cases? Remove the catheter and monitor. Symptomatic infections demand fluconazole, while resistant strains may need amphotericin. Less intervention often yields better outcomes. Prevention of recurrent UTI in women. For women battling recurrent UTIs, options abound. Daily low-dose antibiotics, postcoital prophylaxis, or self-treatment kits. Empowerment through education. Teaching patients to recognize symptoms and act early can break the cycle of recurrence. Non-antimicrobial prevention. Strategies. Cranberry products and probiotics show mixed results, but hydration and hygiene are universally endorsed. Urinating after intercourse, avoiding irritants, and proper wiping techniques are simple yet effective. Prevention begins with everyday choices. Antibiotic resistance is reshaping UTI management. Local resistance data must guide empiric therapy. The stakes are high. Preserving antibiotics for future generations demands prudence today. Factors affecting antimicrobial choice. Geography, travel history, and prior antibiotic use all influence resistance patterns. A drug effective in one region may falter in another. Staying informed about local trends ensures prescriptions hit the mark, safeguarding both patients and public health. Risk factors for resistant UTIs: recent hospitalization, antibiotic use, or travel to high-resistance regions. These red flags signal likely resistance. Urine cultures become non-negotiable here, guiding therapy and avoiding empiric missteps. UTI in special populations. Diabetes, diabetes triples. UTI risk, neuropathy, glycosuria, and immune dysfunction create a perfect storm. Complications like emphysematis, pyelonephritis, or papillary necrosis demand heightened vigilance. Tight glycemic control and prompt treatment are dual safeguards. UTI in special populations. Pregnancy. Pregnancy elevates UTI risks. Hormonal changes and urinary stasis pave the way for infection. Screening for asymptomatic bacteriuria is mandatory. Untreated, it escalates to pyelonephritis in 30% of cases. Safe, timely treatment protects maternal and fetal health. UTI in special populations. Elderly. In the elderly, UTIs often present atypically. Confusion or falls may overshadow classic symptoms. Yet overdiagnosis is rampant. Treat only when clear urinary symptoms exist, avoiding unnecessary antibiotics that fuel resistance and side effects. UTI in special populations. Children. Pediatric UTIs. Hint at anatomical anomalies like vesicoreteral reflux. Uncircumcised boys and girls with constipation are at higher risk. Early diagnosis and imaging. Renal ultrasound, VCUG, prevent long-term renal damage, ensuring children grow up healthy. Prognosis of UTIs. Most UTIs resolve without lasting harm. Recurrent infections rarely damage kidneys unless obstruction or reflux exists. Complicated UTIs, however, demand swift resolution of underlying issues to prevent chronic damage. Knowledge dispels unnecessary fear. Relationship between UTI and chronic kidney disease. Decades-old myths linked UTIs to chronic kidney disease, now debunked. Obstruction, toxins, or reflux drive renal damage, not infection alone. Educating patients alleviates anxiety, emphasizing that recurrent UTIs need not spell kidney failure. Future directions in UTI management. The fight against UTIs is evolving, and innovation lights the path forward. Microbiome research is uncovering the urinary tract's hidden ecosystem, knowledge that could lead to probiotics or microbiome-friendly therapies. Vaccines targeting bacterial adhesins, like E. coli's pili, are in development, offering hope for preventing recurrent infections. Rapid diagnostics, such as point-of-care genetic tests, promise to shrink the gap between symptom onset and precise treatment. Beyond antibiotics, alternatives like bacteriophages, viruses that prey on bacteria, or immunomodulators to boost host defenses are being explored. These advances remind us that collaboration between science, technology, and clinical care will redefine how we conquer UTIs in the decades to come. The urinary microbiome. For decades, we believed the bladder was a sterile environment. Advanced sequencing technologies have shattered this myth, revealing a diverse community of bacteria even in healthy individuals. These microbes form part of the urinary microbiome, which may play a role in protecting against infections. Disruptions to this ecosystem, whether from antibiotics or illness, could predispose individuals to UTIs. By studying these hidden communities, we might unlock probiotic therapies or novel diagnostic tools, transforming how we approach urinary health. Intracellular bacterial communities. Bacteria aren't always transient invaders. Some, like E. coli, can invade bladder cells and form intracellular communities, evading both antibiotics and immune detection. These hidden reservoirs explain why some UTIs recur despite apparent treatment success. Targeting these intracellular niches, perhaps with drugs that penetrate host cells or disrupt bacterial survival mechanisms, could revolutionize how we manage stubborn infections. This discovery challenges us to rethink traditional antibiotic strategies. Biofilms and urinary tract infections. Biofilms are bacterial strongholds. On catheters or damaged tissues, microbes encase themselves in a protective matrix, shrugging off antibiotics and immune attacks. These biofilms turn simple infections into chronic battles, particularly in patients with long-term catheters or structural abnormalities. Prevention, through early catheter removal or antimicrobial coatings is far more effective than treatment. Sometimes the simplest solutions, like reducing device use, yield the greatest rewards. Antimicrobial stewardship in UTI management. Antibiotics are a shared resource, and their misuse jeopardizes everyone. Stewardship means prescribing the narrowest spectrum drug for the shortest effective duration. It means resisting the urge to treat asymptomatic bacteriuria or defaulting to broad-spectrum agents. By educating clinicians, leveraging rapid diagnostics, and tracking resistance patterns, we can preserve these life-saving tools for future generations. This isn't just a guideline, it's a moral obligation. Key principles of UTI management. Successful UTI care hinges on 4 pillars: accurate diagnosis, targeted therapy, stewardship, and prevention. Misdiagnosis leads to unnecessary treatment. Overprescribing fuels resistance. Every decision must balance immediate patient needs with long-term public health. By adhering to these principles, we protect both individual well-being and global antibiotic efficacy. Common errors in UTI management. Even seasoned clinicians can stumble. Treating asymptomatic bacteriuria in the elderly, misattributing nonspecific symptoms to UTIs, or prescribing unnecessarily long antibiotic courses are common pitfalls. Young women with dysuria might have STIs, not cystitis. Learning from these errors, through feedback, guidelines, and humility, sharpens clinical judgment and improves outcomes for all. Patient education for UTIs. Prevention. Empowering patients is half the battle. Simple measures, staying hydrated, urinating after intercourse, and avoiding irritating hygiene products can dramatically reduce UTI risk. Cranberry products may help some, but consistency is key. Teaching patients to recognize early symptoms like burning or urgency ensures timely care. Prevention isn't just a clinical task, it's a partnership between provider and patient. Emerging challenges in UTI management. Antimicrobial resistance is outpacing drug development. Multi-drug-resistant E. coli St. 131 now dominates globally, leaving few oral options for treatment. Meanwhile, the antibiotic pipeline stagnates, with few new agents targeting UTIs. Balancing individual patient needs against societal risks demands creativity, repurposing older drugs, exploring non-antibiotic therapies, and advocating for policy changes. The road ahead is tough, but collaboration can light the way. Let's recap. Diagnose thoughtfully. Distinguish cystitis from pyelonephritis, an infection from colonization. Treat precisely. Match antibiotics to pathogens and local resistance patterns. Steward relentlessly. Every prescription shapes the future of medicine. Prevent proactively. Educate patients and address risk factors. UTIs may be common, but complacency is dangerous. Together, we can reduce suffering, curb resistance, and pave the way for smarter, safer care. Thank you. Thank you for your attention and dedication to improving patient care. Let's carry these lessons into practice. Question assumptions, prioritize stewardship, and advocate for those affected by UTIs. Whether through research, education, or clinical innovation, each of us has a role in shaping a healthier future. Stay curious, stay compassionate, and let's continue learning together. You may practice MCQs on this topic in the posts section of this channel.